Luna, all 4 patients have the same sodium level.
Do they all have the same type of hyponatremia?
That's exactly the question. Luna, what does a high serum osmolality tell you?
Hypertonic hyponatremia.
Excellent. Think hyperglycemia or mannitol. Why is the sodium low?
Glucose pulls water out of the cells, diluting the sodium.
The sodium isn't lost, it's diluted.
Haha!
Effective osmoles stay out the cell and pull water.
So they increase serum tonicity.
Ethanol and urea freely cross cell membranes.
So they don't pull water. Both increase serum osmolality, but only glucose moves water.
Exactly. Only effective osmoles increase tonicity.
So why is knowing the difference important?
Because only effective osmoles determine tonicity. Identifying the effective osmole tells you the type of hyponatremia and the right treatment. Luna, what does a normal serum osmolality tell you?
Pseudohyponatremia.
Excellent. Think severe hypertriglyceridemia or paraproteinemia. Why does the sodium appear low?
The fat reduces the plasma water, so the sodium is measured falsely low.
Falsely low. The sodium in the plasma water is actually normal. What does a low serum osmolality tell you?
This is true hypotonic hyponatremia.
Good. What's your next test?
Urine osmolality.
If ADH is working, the urine becomes concentrated.
So the urine osmolality is high.
When ADH is off, the kidneys dump water.
So the urine becomes dilute, and the urine osmolality is low.
Low urine osmolality tells us ADH is appropriately suppressed.
So how do we tell these conditions apart?
Let's explore them one by one. The kidneys are working normally, but the patient drinks fun.
But the patient drinks more water than they can excrete. So the urine stays dilute.
The kidneys need solute to eliminate water.
Too little solute, less water can be excreted.
Without enough dietary solute, the kidneys can't excrete much water.
So excess water stays in the body.
Without enough dietary solute, the kidneys can't excrete much water.
So even normal water intake can cause hyponatremia.
Luna, let's go back to patient 3. What does a high urine osmolality tell?
The kidneys are conserving water because ADH is active.
Now we need to know whether the kidneys are also conserving sodium.
So the next step is to check the urine.
High urine osmolality means ADH is working.
So now we need to ask, why is ADH on?
Low urine sodium means the kidneys are conserving sodium.
So the body thinks blood volume is low.
Exactly. Next, ask why. A weak heart delivers less blood to the kidneys.
But the patient has edema.
The kidneys sense low effective arterial blood volume. Low effective arterial blood volume activates the ROS.
So the kidneys conserve sodium.
Low effective arterial blood volume also triggers ADH release.
ADH release.
Even though the serum osmolality is low, yes, baroreceptors override the osmolar signal. ADH inserts aquaporin channels, allowing more water to be reabsorbed.
So the sodium becomes diluted.
ROS conserves sodium, but ADH retains even more water.
So water retention wins.
That's why heart failure causes dilutional hyponatremia. Low urine sodium means the kidneys are conserving sodium.
Think heart failure, cirrhosis, or hypovolemia.
Luna, unlike heart failure, this patient isn't conserving sodium.
So the urine sodium is high.
Good. Now ask yourself why.
High urine sodium has different mechanisms.
SIADH, adrenal insufficiency, and thiazide diuretics
All cause high urine sodium. Now think about why. This tumor secretes ADH.
So ADH is released even when the body doesn't need it.
That's syndrome of inappropriate ADH secretion, SIH. Normally, ADH comes from the hypothalamus, but small cell lung cancer is a neuroendocrine tumor.
So the tumor produces ADH instead of the brain.
Exactly. That's ectopic ADH secretion. We've covered ectopic ADH. How do the other causes work?
They stimulate the hypothalamus to release excess ADH.
Excess ADH slightly expands the circulation, suppressing ROS.
So the kidneys stop conserving sodium.
Same laboratory results, but different volume status.
Why is one euvolemic and the other hypovolemic?
Luna, what do these volume states tell you?
Euvolemia suggests SIH, adrenal insufficiency.
But why? Let's find out. ADH retains water, but ANP helps restore a near-normal blood volume.
That's why patients with SIADH are usually euvolemic.
Think of SIH like a bucket with an overflow drain. ADH keeps adding water.
So the bucket stays full, not overflowing.
Exactly. That's why SIH is usually euvolemic. Loss of aldosterone causes sodium and water loss. The low blood volume then stimulates ADH.
So sodium keeps falling while water is retained.
That's why primary adrenal insufficiency causes hyponatremia. ADH tries to replace the lost water. But without aldosterone, sodium and water keep being lost.
So ADH can't fully restore the blood volume.
Think of it like a leaking bucket. ADH adds water, but without aldosterone,
Sodium and water keep leaking out, so the bucket never fills.
after confirming hyponatremia, what's the first test?
Serum osmolality. It tells us the type of hyponatremia.
What's our next question?
Is ADH active? Urine osmolality gives us the answer.
And our final question?
Is RAS on or off? Urine sodium reveals the mechanism.